Thanks, Richard. That was great. I wonder if anyone has any questions at this time for Richard.
That was absolutely fantastic. Thank you very much indeed. And I've only just got two quick questions. The first one, and I run Centres for Survivors of Childhood Trauma, healing centres, and we've helped over 4,500 people over 12 years. And in our training of our workers, we always talk about face-to-face contact on the basis of the research from Cozzolino, etc., which is that the optical neurons are the strongest. And we find that actually face-to-face, the person doesn't have to look at us, is really impactful. So I'd love you to reflect a bit more on your decision on being by the side rather than engaging them, so if they wish to, they can get that healing and the integration.
What I meant was not being confrontational. I was talking more about the acute ward situation. People good-naturedly sit on the edge of a patient's bed without thinking what's happened to them in beds before, and I meant to not be confrontational, to be thoughtful about it. In the psychotherapeutic work that I do, it's very much face-to-face. It's all about recapitulating the proto-conversation. It's all about eye contact. It's all about re-regulating the neural circuitry in a face-to-face environment.
Fantastic. One other quick just comment or question. When you were talking about people being triggered back into their trauma, you talked only about it being interpersonal, but in my experience, often people can be triggered by inanimate objects, such as the colour of curtains where they were abused or being raped in a car. And I just wanted to add that for anyone who wasn't knowledgeable about the ways people can be triggered, that inanimate objects can trigger people in just the same way and be just as confusing to them, that this may be the cause of their problems.
Look, I did skip over that yesterday. If you look at yesterday's slides about Ellenson, I did talk about those sorts of things. That's a sort of complicated implicit memory that's been laid down during an experience. So I mentioned the barking dogs, for example, in the case of Susie. So all sorts of things can come into that experience.
But thank you, it was fantastic.
Hello, look, I'm a coordinator of a sexual assault service. I was involved in setting up sexual assault services in New South Wales and been involved working with children who've been sexually assaulted since 1986. And I want to say thank you, because this is such an important conference, and everything that's been said by the speakers just resonates so much with my own experience, and obviously our learning has been increased over the years with the work that's been done in recognising trauma, but it's about how we're going to be working together. And I hope maybe there'll be an opportunity later where I might speak about that a little bit more. But I guess I know many here, and I myself, in terms of within Sexual Assault Service Program, worked for years to try and impact on, with each inquiry, etc., that's occurred in trying to get child protection focus, in trying to look at the impact of childhood trauma, and without experience change all over this time, and to look at simple things like parenting programs as being the solution. So I guess I'd say this. Someone mentioned, I think, the word movement yesterday, that we are needing to start a movement together, but to be working collaboratively to try to begin to impact on that and introduce change. And I know I've been very heartened by this, but also disheartened by Richard's perception that it's going to be another 30 years perhaps before we achieve that. But I would really like to look at how, with other programs who are working with trauma, that we can all be working together. Thank you.
Got an answer? No? Oh, next question.
I think that was rhetorical.
I'm Brenda Page, and I work in a pure mental
Sorry,
health.
I can't see anybody over there. That's why I'm sort of squinting. But keep going.
In a pure mental health service here in New South Wales. I would like your thoughts on the trauma that's related to psychosis and first presentation of people with psychosis and the trauma that they have experiencing the psychosis. Having worked in drug and alcohol and mental health, I think that we often see patients who have been quite traumatised by that experience of the psychotic episode, but we actually don't deal with it particularly well, I don't think.
If there are too many psychiatrists around, I'll start looking a little bit heretical, because what I do is I use the principles I've learned in psychotherapy training to inform my work with everybody. So when somebody comes in with a psychotic condition, they start talking and I listen and I go wherever they need to go, plus I look at all of their symptoms. So I usually try and take that on board. I could talk about the conversational model for about 8 weeks, and I probably should have put it in the talk. One of the great things about the conversational model is that you have a to and fro and interchange, and what you work on is what happens next. So if somebody starts telling you that it's been traumatising to be psychotic and you ask them what their voices are like, then you'll see in their face a response that doesn't match the sort of response you should be having when you're having an interaction. So we should be able to incorporate all of those things.
Because I don't think we actually recognise it enough, and I don't think we do it particularly well.
No, I'm sure you're right. And I can only say, I can only repeat myself that if you understand about trauma broadly, you can apply it to so many different situations. And you can follow wherever the person is in front of you is going. The thing about learning psychiatry and learning psychotherapy is that you can have a relationship and be therapeutic while you're doing all the things you need to do as a psychiatrist, because you need to do those as well. And it's a sort of complicated thing, but the two need to go together, in my opinion.
One more question. Just one. Hi, I'm a mental health nurse and I've worked in acute inpatient units and community mental health in New Zealand and Australia. I have found this whole thing to be incredibly validating, this whole thing, as I mean the conference, incredibly validating for me. In my experiences in Australia, I've actually found myself to be ostracised by staff when I've actually tried to support clients when they've been re-traumatised or re-victimised. That's happened to me in Australia. I worked in the mental health nurse incentive program in Tasmania, I'm sorry to say. I loved Tasmania, but it wasn't in Hobart where you are. But when I tried to work with the public mental health service and the emergency department to help with clients to have a consistent approach and supportive approach when they fronted to ED, I pretty much got laughed out of the arena. I ended up leaving Tasmania because it was way too traumatic for me, and I felt like I was actually wrong as a mental health nurse. I wasn't doing the right thing, so this has actually been incredibly validating for me. Thank you. And I just want to mention one more thing. A couple of days ago at work, I work casually in an acute inpatient unit in Auckland in New Zealand. I was with a patient who was huddled in a chair cuddling a teddy and a doll, and I just sort of knelt down in front of her to talk to her. I got pulled up later by the coordinator for putting me at risk and everyone at risk for putting myself below her. I should have been standing over her. So, yeah. Thank you.
Okay, thank you for those questions and sharing those experiences. I think those of us who've worked in the mental health system are with you on that. I think we've all been there, or probably many of the people in this room. And I do want to say that I guess part of what we're coming to now is, you know, people like Richard, people like Louise. There are many people in the mental health system who want things to be different but really struggle within it. The same for the non-government sector as well. I guess out of today, and Kathy Kesselman will help us with this later on this afternoon, we will try to bring together the kinds of things that we've heard throughout these 2 days and think about, well, where to from here? How are we going to make this, you know, this shared understanding of how things should be? How are we going to make that, you know, move things along and slowly change our system, and hopefully earlier than 30 years, as Richard's predicted. But I'd like to thank Richard for his presentation. I think he's a gem.